introduction, and thank you for inviting me. I've kept today's session on very basics, just to introduce what neuroradiology is, the INR. But this is the terminology which is used for this modality is also interventional neurology, neurointerventional surgery, or endovascular neurosurgery. So it really depends where it is being practiced, who is practicing. The program is run by a neurosurgeon or a neurologist, because at the moment, radiologists, neurosurgeon, neurologists, all are practicing endovascular procedures, especially in USA. In Japan, most of the procedures are done by the neurosurgeons, but in Europe, the trend is still the modality is dealt by the radiologists at the moment. So I will be more focusing on the basics, a little bit of the history that may interest you. These procedures, especially the diagnostic angiographies, they were introduced a long time ago, 80 years back. In 1927, it was again a neurosurgeon, a Portuguese neurosurgeon, Moniz, who did the first carotid puncture angiography. So before the invention of the CT and MRI, the space-occupying lesions, the tumors, were diagnosed on the basis of angiography, because this was in place even before the CT scan and the MRI. So angiography used to be done, and on the basis of that, the space-occupying lesions were diagnosed, and on the basis of same, the surgeries were performed. So CT came in 1972. Before that, so I have picked up this small video clip from a movie. You can see that how this direct carotid punctures used to be done, and what was the old methods of radiography. We used to take lots of films, rapid sequence. In one angiography, there used to be like 50 or 60 hard films. So the procedure was read, and the exam was read on the hard films rather than on the computers.
You know, I have done this looking at those hard films when I was a resident, actually.
Okay. So I think in Karachi, this was first introduced by father of Dr. Jumma, who used to do it at Jinnah in the 50s and 60s. And Dr. Jumma was telling me he also used to do this the procedures by himself.
Yeah.
So for one examination, they used to puncture both the carotid arteries and even the vertebral arteries.
Is this actually, yeah, they are actually doing it, right?
No, this is Exorcist movie.
Oh, it's
1982.
I see. Okay. Pretty good drapes in those days also.
Yeah. I think it's a UK-based movie.
Exorcist was a US movie, though.
USA? Okay.
Hollywood movie.
So these were, even at that time, 1982, they were biplane, but both planes were, again, hard copies.
Mm-hmm. Cut.
Gee. There's a lot of sound from there.
Yeah.
And these were the films which we used to read. There was no DSA, no subtracted images. So we still have to find out the vessels within the bones. So the bones were there. So this was the old method of doing the angiography, but now we have got the computerized technology and this is called DSA. But now we have got other modalities which are performing the diagnostic angiographies, which is the CT and the MRI, and they have got very good resolution and excellent for initial screening. So you can just compare the three modalities, CTA versus MRA and versus DSA 3D. So very comparable, very good resolution. DSA is still the gold standard, is still having the best resolution for even for minute details. When you are studying the morphology of the aneurysm, then again, DSA is being the gold standard. But for initial screening, the CTA and MRA are good enough. So how we perform the procedures, the routine still the method of performing the procedure is transfemoral. So we approach the cerebral arteries by puncturing the common femoral artery. The catheter go all the way up through the aorta into the carotids and the vertebrals. And recently, people have also introduced, we are performing the peripheral angiographies by radial approach. The cardiologists are using this approach quite often. So the cerebral angiographies and even the interventions can be performed now with radial approach. So we puncture through the radial artery, we place a maximum of 6 French sheath, and through that sheath, we can perform the entire aneurysm coiling or AVM embolization. This is a typical angiographic suite. This is our old machine, which is a monoplane. There is single C arm which rotates around the patient. It rotates sideways, it rotates cranial and caudal as well. And there is direct fluoroscopy. We can see the, on fluoroscopy, we can see the catheter placement, the catheter visualization, the wire visualization directly on these computers. And then when you perform the run, you inject the dye and you acquire the images, which can be at the maximum speed of 7.5 frames per second. So it's a very high speed. For AVM, we require a very high frame rate. Otherwise, for aneurysm, the routine is 4 frames or 2 frames per second. The cardiologists, because the heart is moving all the time, they use 15 frames or 30 frames. Their machine is a little different from ours, and they don't use the DSA. We always do. We always use the DSA. Their angiography is called DA, digital angiography. And when we subtract the images and we don't see the bones, we call it digital subtraction angiography. This is a typical neurointerventional suite, biplane. That is a standard of care now. We definitely need a biplane for performing the procedures now. It gives additional advantage of having both planes at the same time. So we inject once and we acquire images in 2 different planes. Even with while doing the fluoroscopy, while aneurysm coiling, we are looking at the aneurysm at 2 different planes, whatever we feel like. Okay. So how this subtraction is done? The images are first acquired in plane. Plane scanning is done first so that the bones are visible before injection of the contrast. Then we inject the contrast into the blood vessel. Okay. The initial image is called mask image and then followed by a digital angiography image. So the DA image is then subtracted over the mask image so that you only get the vessels and the bones are all subtracted. If there is a little bit of movement in between the mask image, sequence runs at the same time. First, there are three or four mask images. The computer by itself picks up the best one and subtract the later on images with the contrast over that mask. And if there is a little bit of movement, you still see the bones. But if there's no movement at all, you don't see the bones not at all. Okay. So this is how digital subtraction angiography is done. It is all done by the computers. We don't have to do anything manually. Okay, coming to the vascular anatomy, you want to ask any question up till now, if anybody? If anything is not clear.
So the participants can raise hands and we can see in the chat box, or they can write the questions in the chat box and
Sure.
we can answer them.
Right.
So Tanveer, there must have been a lot of difficulty at the skull base level because there's so much bones, right, Hannah?
They are also subtracted, but the resolution.
I'm talking about in the initial ones when
Initial ones, yes, you're right. Yes. When there was no subtraction, the bones, especially as you said, base of the skull के ऊपर काफी hindrance होती थी, काफी वहां पर नजर नहीं आती थी चीजें, तो difficulty होती थी. That's for sure. जी बिल्कुल. लेकिन जब से ये DSA है, तो we don't have any, usually don't have any difficulty.
Right.
So regarding the vascular anatomy, there are 4 vessels which are going up into the cranium, 4 major vessels. The 2 vertebral arteries and the 2 internal carotid arteries arising from the arch of aorta and the subclavians. The vertebrals arising from the subclavians. The right common carotid comes out as brachiocephalic artery and then divides into subclavian carotid and then into external and internal carotids in the neck. And then it runs up. And the further anatomy is, these are the 2 standard views which we always take. That's the frontal view, which is the anterior-posterior view, AP view, and the lateral view. Then we do further views as obliques, different obliques, different projections. But now especially for the aneurysm, we perform a 3D first. First a standard AP lateral view, then 3D, and then on the basis of 3D, we find out a good projection in which you can see the neck of the aneurysm, the dome, and the native vessel from where the aneurysm is arising. And according to that, we perform the 2D images. So on the AP view, you can see the internal carotid artery. And here is the terminus bifurcation into anterior cerebral artery and the middle cerebral artery. The first part of the anterior cerebral artery is called the A1 segment, and the first part of the middle cerebral artery before its bifurcation or trifurcation is called M1 segment. Okay, A1 segment is up to the ACOM segment, where when it joins the ACOM, then it becomes the A2. On the lateral view, there are usually no branches of the internal carotid artery in the neck. But when it enters into the cranium, it gives off branches. Initially, there are meningeal branches, meningiohypophyseal trunk. And then when it passed out from the cavernous sinus, the first branch which comes out, which is the supraclinoid part of the ICA, is the ophthalmic artery. Okay, so one anterior artery, which is the ophthalmic artery, and 2 posterior arteries. The first one is the PCOM, and the upper one is the anterocoroidal artery. The PCOM might be absent, might be very small, might not be visible on the internal carotid artery. And in this case, there is a small PCOM and there is anterocoroidal, which is quite good sized anterocoroidal artery. So 3 branches first and then the bifurcation. Okay, so we can divide the internal carotid arteries. The basic division is cervical portion, the petrous portion where it runs into the bone. Then it runs into the cavernous sinus, is still extradural. Within the cavernous sinus, that's the cavernous portion of the ICA. It comes out from the cavernous sinus. It gets into the subarachnoid space, where it divides, where it gives off the ophthalmic artery, the PCOM, and the anterocoroidal artery, and then the terminus. Okay, the division can be C1, C2. The C2 is the petrous part. C3, where it passes through the canal into the foramen. It comes out and enters into the cavernous sinus, where it is C4, cavernous portion. It is extradural. Then supracavernous part before it gives off the ophthalmic arteries, then ophthalmic part, and then the communicating part where it gives off the posterior communicating artery. So the division can be like C1, C2, C3 up to C7, or it can be just cervical, petrous, cavernous, and supracavernous or supraclinoid part. Okay. आप लोग सर्जरी में क्या यूज कर रहे होते हैं? Is it the C1 to C7 divisions or just the cavernous supraclinoid? Then the posterior circulation, as I said, the two vertebral arteries arising from the subclavian arteries, they goes up and join within the cranium and forms the basilar artery. Before joining and forming the basilar artery, they gives off the pica. The pica can be very small or they can be very big, and sometimes a conjoint one. Then the basilar artery gives off two icas on side by side, and higher up at the terminus, where it's divided terminally into posterior cerebral arteries, and before that it gives off superior cerebellar arteries. So there are 6 arteries supplying the cerebrum, 3 on either side: the pica, posterior inferior cerebellar artery, the ica, anterior inferior cerebellar artery, and superior cerebellar arteries, and the posterior cerebral artery arising from the terminus of the basilar artery. And this is the lateral view. The two vertebral arteries, the basilar artery, the posterior cerebral artery, the superior cerebellar artery, the ica, and small picas over here. And these are the meningeal branches which comes out initially from the vertebral arteries, and then there are muscular branches as well from the extracranial part of the vertebral arteries. Okay, and the vertebral arteries can also be divided into 4 parts. V1 before entering into the foramen of C6, and then V2. Then it comes out from the foramen of C2, where it becomes V3, and then it enters into the foramen magnum. From the skull base, it becomes C4, which is usually the intracranial part of the vertebral arteries, and from the V4 segment, it gives off the pica. Regarding the venous anatomy, they are superficial cortical veins, the deep cerebral veins, and the dural sinuses. So that forms the venous structure of the brain. The superficial cortical veins are not named. They are multiple, numerous. Only few of them are named. For example, vein of Trollard and Labbe. Labbe is quite important because it drains out from the temporal lobe. We take special care of vein of Labbe when we are embolizing AVM or dural fistulas, because the thrombosis of Labbe can lead to infarct in the temporal lobe, and on the left side it can lead to aphasia. The deep venous system, the internal cerebral veins, the vein of Galen, the two internal cerebral veins and basal veins, it joins the basal veins to form the vein of Galen, and vein of Galen drains into the straight sinus towards the tocula. Okay, similarly, the superior sagittal sinus drains into the tocula, and then tocula divides into, on either side, the transverse sinuses, and inferiorly the sigmoid sinus, which enters into the jugular vein. Okay, sometimes the one transverse sinus is prominent and the other one is a smaller or hypoplastic. So right one is majority of the times is larger than the left side. The anterior part of the superior sagittal sinus is not always visible. It appears to be small. On angiography, the inferior sagittal sinus is also very faintly visible. It's not that good, but you can see it on MRV very well. On DSA, because of the flow dynamics, it's not very well seen. but other veins are picked up nicely. Then there's cavernous sinus, which drains into the superior and inferior ophthalmic veins, and inferior petrosal sinus and superior petrosal sinus. So two petrosal sinuses. We use this inferior petrosal sinuses for sampling when we require it for the ACTH levels from the pituitary gland. So we take direct blood from the inferior petrosal sinus to examine the ACTH in cases of Cushing's disease. Superior ophthalmic vein,
and for that you go
from the jugular vein.
Jugular vein, right?
Yeah, we can do direct puncture of the jugular vein. That's simple. Or we can go from the femoral vein to get into the jugular vein. Ophthalmic vein it becomes very, very prominent in CCFs, where the carotid has got a fistula into the cavernous sinus. The cavernous sinus becomes very much enlarged, and the ophthalmic vein is very much enlarged. So this sometimes is our route for embolizing the CCF. We go through the angular facial vein into superior ophthalmic and then into the cavernous sinus, or from the inferior petrosal sinus into the cavernous sinus when it is present. The circle of Willis, the two anterior cerebral arteries joins in the middle by ACOM, and the two PCAs joins the internal carotid artery through PCOMs. So that's how the whole circle is formed through ACAs, ACOM, ACAs. In between is ICA, then PCOMs and PCAs. So the part of the PCA which is before the PCOM is the P1 segment. This is a very, very important segment because it gives off the perforators, the artery or Percheron sometimes, the supply to the thalami and supply to the midbrain. PCOMs also gives off perforators. They are very important. So these two vessels are very, very important. If A1 segment of the ACAs also gives off perforators, the lenticulostriate arteries. So they are again very important. So on MRI, you can have a similar view, a basal view, a very nice basal view. You can see the whole circle of Willis. Again, the ACOM, ACAs. These are the ICAs. You can see the PCOMs over here, okay, and the PCAs. This is the basilar artery, okay. So that's how you can see the circle of Willis, whether it is intact or sometimes you don't see the PCOMs. They are small or absent, or sometimes the ACOM is very small. And then there are vascular variants. We have to take care of them as well. You can have one side dominance. For example, the vertebral arteries, majority of the times, the left vertebral artery is dominant. But sometimes you see right as dominant. The one is smaller than the other. Sometimes both are equal in sizes. Sometimes they are common origins. For example, in this case, there's a common origin of the PCA and the superior cerebral artery. Sometimes you have one single trunk, which is giving off the ICA and PICA. Sometimes the PICA is very prominent and there is the ICA is very small, rudimentary.
Tanveer, go back to the last one. If you can please. So उसमें third nerve कहाँ पर आएगी, right वाली, right side पे? You could typically third nerve is between the SCA and PCA. So इसमें क्या displace भी होगी? I just wonder.
इसकी यहाँ की बात कर रहे हैं इसमें?
हाँ. Or it would be just like where the arrowhead is, probably.
Yes, I mean, you're right. You're right. मुझे exactly नहीं पता. I have to.
So yeah, I've never seen this picture. I've never seen this picture.
Yeah. अभी हमने एक एंजियो किया था अभी इसी वीक में जिसमें ये anatomy थी. There was a common origin of both the arteries.
So अगर उसका MRI हुआ है, तो it will be nice to look at the third nerve कि वो कहाँ पे located है.
Oh yeah, okay.
That pushed over.
Right. Okay, it may be.
All right, ठीक चले.
Then we have a very common finding, infundibulum of PCOM. You sometimes have a small dilatation, a triangular type of the origin of the PCOM. So it is sometimes confused with the aneurysm. It's not an aneurysm, it's just a normal variant dilated origin of the PCOM. So I was just looking into the literature. We just got a patient last week in which there was a big subarachnoid hemorrhage. We couldn't find any aneurysm in that patient. And this is from the same patient, we found this infundibulum. So there are case reports in which people have taken these as aneurysms and treated them for subarachnoid hemorrhages, but there are few cases only. Majority of the times, the infundibulum do not bleed. But it is considered that the size of the infundibulum are usually less than 3 millimeter. But if they are bigger than 3 millimeter, then they can bleed.
I have clipped one with Dr. Malik many years ago.
Okay.
Because, so we did all the tests. And
was that a larger size?
It was a larger size. It was not like typical conical pyramidal जो होता है infundibulum. And there was a blister at the point, sort of blister, not exactly blister, just before the PCOM comes out. So,
तो infundibulum हम जब भी कहते हैं जब उसके अपेक्स से PCOM निकल रही होती है, लेकिन अगर PCOM का origin उसके साइड से है from the neck, then it is called an aneurysm. Definitely, then it's a blister aneurysm.
नहीं वो blister जो था, blister was at the tip of the cone, right?
Okay. I see.
Okay. It was an infundibulum which had itself become an aneurysm. ऐसा लग रहा था.
Okay, I see. Okay. Then we have got this fetal posterior cerebral artery, dominant anterior cerebral arteries. These are other variants. In this case, you can see the anterior cerebral artery. Both of them are filling up from the left side, and there is a small ACOM aneurysm arising from the ACOM. So this, we call it a dominant anterior cerebral artery because this is supplying both the sides. The right one is a smaller, although it's filling up. Sometimes you don't see the A1 segment at all. Sometimes it is hypoplastic in 10% of the cases, and sometimes it's absent, absolutely completely absent in 1% of the cases. Okay. So in those cases, it becomes very tricky. If you don't have the A1 segment on the other side and both the anterior cerebral arteries are filling from the two sides, you have to really take care of the ACOM. It should not be compromised in clipping or coiling because it will lead to AC infarct.
एक चीज जो कि वो इसमें आप बता दें, this is a nice picture of showing how the AP view में आपको PCOM से PCA और P2 और P3 सारी नजर आ रही हैं.
जी वो मैं अगली पिक्चर पे दिखाता हूँ. एक मिनट, वो आ रहा है, मैं इसको दिखाता हूँ. I think this is again a variant in which instead of an ACOM, you have got a single trunk, which is called the azygous artery. Initially, the A2 segments are joined, called the azygous artery, and then they divide into two A3s. मेरे ख्याल में ये Fox से पहले ये होती है, फिर जब Fox आ जाता है तो ये दोनों divide हो जाती है on either side of the Fox. And this is a case in which there is an aneurysm sitting at the azygous artery. The incidence of aneurysm is quite high when there is azygous. Although azygous artery, the incidence is 1%, but if it is there, the incidence of aneurysm is 41%. And it is associated with the dysgenesis or agenesis of the corpus callosum.
Nice.
So this is a fetal posterior cerebral artery in which the PCOM is very prominent and it's supplying the posterior cerebral artery. And there is no, this is the left ICA, there is no left P1 segment. This is the vertebral angiogram. This patient was having subarachnoid, so you can see spasm there. In the vertebral artery, in the basilar artery, and there is good P1 and PCA arising from the basilar artery on the right side, but there is nothing on the left side. So left side is filling up from ICA through PCOM. So this arrangement is called fetal posterior cerebral artery, the dominant PCOM, which is supplying the PCA, and it is quite common. So for an aneurysm arising from the PCOM area or the PCOM, if that is incorporated into the neck or into the body of the aneurysm, then you have to really take care of this fetal posterior. You have to first establish whether there is P1 on the vertebral angiogram, and then you have to take care of the PCOM. You don't have to compromise the PCOM, otherwise there will be a PCA infarct. This patient presented with subarachnoid hemorrhage. You can see blood there at the base of the skull over here, and an aneurysm. But this is a little unusual location. It's quite low in the C3 part, where it comes out just before the cavernous sinus, and you can see this vessel which is joining the basilar artery. Okay, this is on the other view. You can see the basilar artery and the whole posterior circulation. This is a vertebral angiogram, and this is the left internal carotid. On both these runs, you can see the same vessel. You can see this aneurysm. So this is persistent trigeminal artery. Okay, again a variant in which there is an aneurysm as well. So when we saw that, we coiled that. So you can have different communications between the ICA and the posterior circulation. Higher up is the trigeminal artery, and lower down you can have acoustic artery and the hypoglossal artery.
I've never seen acoustic and hypoglossal, but I've seen.
अभी एक केस था उसमें हमने देखा था very low down there was a communication.
Do you have a sense
very rare, but trigeminal is not that rare. The incidence is again very low, 0.2%, और बाकियों का इससे भी कम है.
So I've only seen trigeminal, but have you any sense that this is little more common in our part of the world, or it's about the same? It looks like.
अभी 20 साल में मैंने शायद तीसरा केस देखा होगा. ये 3 केसेस देखे ट्राइजेमिनल के, और एक अभी हाइपोग्लोसल था recently. So we did the balloon remodeling, coiling of the aneurysm. We blocked the trigeminal artery because the basilar artery is nicely filling up from the vertebral, so that's why we blocked this. So you have to be careful whether the vertebral arteries are good or not. If the flow is primarily from the terminal, which is, if that is very prominent, then you have to you don't have to block the trigeminal artery. So in this case we blocked it, and you can see on the vertebral run you are not specifying the aneurysm at all. So that's the small rudimentary trigeminal segment over here post coiling. These are the perforators which are arising from the P1 segment, as I already told you, and supplying the two thalmi and the midbrain. Sometimes you have a single trunk supplying both the thalmi. So infarction caused by occlusion of this artery of Percheron will lead to bilateral thalamic infarcts. So sometimes, rarely we see that. So coming to INR, we have got procedures which have definitely replaced the surgical procedures, have considered now the primary procedures for treating these conditions like brain aneurysms, spinal AVMs, dural fistulas, vein of Galen aneurysms, carotid cavernous fistula, injuries. But the procedures can be adjuvant to surgery in AVMs, in tumors. Now we have got standard of care treating the ischemic stroke as well, removing the clot mechanically by thrombectomy, mechanical thrombectomy. We used to do thrombolysis by fibrinolytic agents some time ago, but now we have got strand retrievers and aspiration devices by which we perform the mechanical thrombectomy. So we can also treat the carotid artery disease, intracranial stenosis as well. The terminologies: embolization. Any embolization means to block. And the blockage can be with the help of particles, liquid embolics like glue, onyx, squid, fill, different names for different agents, coils, which can be detachable or pushable, detachable balloons. Revascularization is to open the blood vessel by angioplasty or stenting, and clot management. So these are three basic techniques. Aneurysm coiling, the different techniques which we use is a simple coiling of the aneurysm when we have got a favorable neck of the aneurysm. But if it is a wide neck, we use balloon-assisted coiling or a stent-assisted coiling. Balloon-assisted coiling if it is an acute rupture case, stent-assisted if it cannot be done by balloon, and at least 3 weeks have gone past from the subarachnoid period of subarachnoid hemorrhage. So we can place a stent and coil the aneurysm. Flow diverters is now treatment for very large aneurysm, very wide neck aneurysm, large aneurysm, and giant aneurysms. VAP can also be used for wide neck aneurysms. Pulse Rider, another tool for treating the wide neck aneurysms. This is a simple example of ACOM aneurysm over here, and how this is done. We place a microcatheter over the wire into the aneurysm first. This is the microcatheter, and then we push the coils into the aneurysm. That's the deployment of the coil. You can see on fluoroscopy. This is a roadmap. The picture is visible on your monitor, and on this image, you are deploying the coil into the aneurysm. Okay, so there's just a packet, completely fill the lumen with the coils. Dense packing is always good. The chances of recurrence are low, but if it is not a dense packing, then there can be recurrence. So this is the final image, the packing of the aneurysm, and that's the DSA. There's no filling of the aneurysm now. AVM embolization, the cure rate for AVMs is very low with embolization procedures. We can perform a cure for very small AVMs if the feeders are 1 or 2, especially for the fistulas. If you see a direct fistulas, you can treat them very well. But majority of the cases, we perform as adjuvant to surgery before radiosurgery or before surgery. But for dural AV fistulas, the success rate is high, and this is considered the primary treatment for the dural fistula. I'm skipping this video because of the time. This is our case in which there was a compact nidus of the AVM supplied by the posterior cerebral artery. That's the main feeder. You can see the occipital AVM, our compact nidus supplied by that's the venous drainage into the vein of Galen, so all deep veins filling up. So we went into those branches of the nidus, feeders of the nidus, and then embolize it with onyx in this case. And you can see the cast of the onyx is almost completely occupying and filling up the entire of the nidus. And there's a final image. You don't see the filling of the aneurysm, but still for these large AVMs, surgery is always good. So surgery was done by Atharinam, and there's a post-surgical image. You don't see the AVM at all, no filling now. So it's cured, it's treated. For dural AV fistulas, like in this case, there was a fistula, there was a dural AV fistula. This patient presented with venous hypertension, gait disturbances, and we saw this dural fistula over here. So we always try to get into the middle meningeal if that is supplying the fistula. We try to get into the nidus, and there's an aneurysm sitting at the fistula. So we get into the fistula. You can see a draining vein, large draining vein over here. And then both the transverse sinuses were occluded in this patient. Okay, that's why there was severe venous hypertension. There was all cortical retrograde filling, reflux, and the drainage is mainly from the deep system. So we embolized this fistula with onyx, and that was cured. And after the procedure, there wasn't. And then we did the angioplasty of the transverse sinuses as well. So that was the initial image in which there is a very severe stenosis of the transverse sinus. We ballooned it, and that's the final run in which we see the opening up of the transverse sinus. This is another patient in which there was a vein of Galen malformation, large vein of Galen. So you can see a fistula, direct communication of the choroidal artery into this large sac, which is the remnant of the vein of prosencephalon. So we embolize this fistula, and that's the final run.
What was that? A vein of prosencephalon is
this sac is the vein of
where is that?
prosencephalon.
Is that? Sorry.
Yep. So the pouch which we see in which is a misnomer actually. It's not a vein of Galen, it's the vein of prosencephalon remnant. So vein of Galen जो बनती नहीं है ऐसे patients के अंदर. और फिर एक तो स्ट्रेट साइनस होता है, वो कभी कभार बंद हो जाता है, और फिर ये सब फेल्साइन वेन होती है बड़ी सी, वो खुली रह जाती है, तो उससे ड्रेनेज हो रहा होता है. तो ये because this was simple fistula, we embolized it and it was cured. And you can see the difference. That was the initial large sac over here, and this is the MRI after 1 year. The sac, there is no flow void, it's completely thrombosed, it's very small size, hydrocephalus is gone. So carotid cavernous fistula, again, is very rewarding. Majority of the cases are cured by endovascular procedure. Success rate is above 80%. We use detachable coils or detachable balloon. Detachable balloon availability is difficult, but still we are getting in Pakistan. In USA, they don't have the detachable balloons, I guess. They always use the detachable coils. So it's simpler. It is much cheaper because you have to fill up the cavernous sinus with the detachable coils. So too many coils are required. The procedure becomes very expensive then. And with the balloon, either majority of the times a single balloon is good enough to occlude the fistula. So this is a case in which a huge carotid cavernous fistula, you can see the cavernous sinus, huge, draining through the ophthalmic vein. The artery, carotid artery, and the jugular vein are seen at the same time, which means that there is a very high flow on the angiogram, and the distal flow is very sluggish. You see very sluggish flow into the distal normal arteries.
And the ophthalmic is also.
Ophthalmic is very much hypertrophied and large superior ophthalmic vein. So this was treated by two detachable balloons. And you can see the fistula, which is completely occluded now. No ophthalmic vein, no jugular vein. The distal flow is good now. And there is no fistula, cavernous sinus filling. So this is very rewarding. So this was initial. After embolization, 2 weeks, all chemosis, redness has gone. Spinal AVMs. This was a case in which a big dural fistula, huge, which was treated, and it was cervical. And it was treated with detachable balloons and coils as well. And the fistula was closed. The patient was completely paraplegic initially, and then he could able to walk. After some time, it is another case in which there was perimedullary AVM, which was embolized with onyx. And this was the child which was not able to walk at all. After the procedure, he was walking. So these are the procedures which now there's a lot of development in endovascular techniques and procedures. The conditions which were once said to be untreatable. I remember this for the CCF patient used to occlude the ICAs. There were clips which they used to tight each and every month, applied on the neck to occlude the ICAs to treat the CCFs. Now we have got the endovascular techniques. So you need to develop the skills. The procedures are expensive. They are very sophisticated equipments. We need to learn and acquire these skills, how to use them. And the treatment of acute stroke is a revolution. Since 2015, it has become a standard of care. We can reverse the stroke completely if the patient is presenting within 6 hours. So I've completed my presentation now. We can